Hello everyone, today we will be discussing Clostridium difficile infection, as it is a major health threat. It is associated with high mortality and morbidity. Clostridium difficile is recognized as one of the most important pathogens in hospital and community healthcare settings, with a steadily rising global incidence of infection and concordant increase in mortality. Clostridium difficile, also known as C. diff, is a bacterium that causes diarrhea and colitis. It is a gram-positive spore-forming anaerobic bacillus that was first described in 1935 as part of the intestinal flora of infants. Infants are colonized by C. diff up to 70%, and it drops to about 3% after 2 years. It is part of our GI flora. In 1978, it was recognized as a pathogen responsible for many cases of antibiotic-associated diarrhea. C. diff is also present in the environment, in the soil, water, and animal feces. If you touch a surface contaminated with C. diff, you may be unknowingly ingesting the bacteria. According to Curry et al., recent evidence suggests a longer incubation period, even greater than 1 week. It is very resistant and highly transmissible. C. diff spores can survive up to 5 months. Humans and contaminated environments are the reservoirs. General facts. According to the CDC's Emerging Infections Program population-based surveillance system, Clostridium difficile infection is the most common cause of healthcare-associated infections. It costs the U.S. up to $4.8 billion in excess costs each year for acute care facilities. 64.7% are considered to be healthcare-associated infections in which symptoms onset happen 3 days after admission, while 35.3% are community-associated infections in which the onset of symptoms are less than 3 days after admission. About 500,000 people are infected each year. 1 in 5 patients can exhibit recurrence. Within a month of diagnosis, 1 in 11 people over the age of 65 died of a healthcare-associated CDI. An important note is that incidence was highest among those older than 65, and it was also greater among females and whites. CDI is associated with 15,000 to 30,000 U.S. deaths. Studies show that overall, 94% of all cases of CDI had a recent healthcare exposure. C. diff now rivals MRSA as the most common organism to cause hospital-associated infections in the U.S. C. diff produces 2 toxins causing tissue damage in the GI tract, resulting in mild to severe diarrhea, toxin A and toxin B. Toxin A leads to diarrhea by damaging the villus tips that disrupt the brush border membrane, leading to cell erosion and fluid leakage. Toxin B causes the opening of the tight junctions of the intestinal epithelial cells to increase vascular permeability and induces hemorrhaging, leading to severe damage. Sequence leading to infection is caused by alteration of the normal gut flora, usually from antibiotic treatment without enough healthy bacteria. C. diff can grow out of control, producing the toxins. What does C. diff do to the gut? After 24-hour exposure, it's normal. After 30 hours, there has been growth and production of toxins causing tissue damage and inflammation, usually by toxin A, which is then exacerbated by toxin B, and one attains diarrhea, and spores then leave to await the next host. How do you get CDI? Antibiotic exposure, especially to the 3rd, 4th generation cephalosporins, fluoroquinolones, carbapenems, and clindamycin, they are found to be high risk. The disruption of the intestinal microbiota is long-lasting, and risk increases during therapy and in the 3-month period after. The highest risk is during and in the 1st month after antibiotics. Another risk factor is previous infection. After a first diagnosis, 10 to 30% of patients develop at least 1 recurrent CDI episode. The risk of recurrence increases with each successive recurrence. A national estimate of first CDI recurrences in 2011 was 83,000. CDI is associated with a 33% increased risk of mortality at 6 months. Also, advanced age. CDI among persons more than 65 years of age is an important factor, along with the duration of hospitalization. Elderly that have numerous comorbid conditions and have been exposed to antibiotics are bound to have C. diff, colonization, and infection. The immunocompromised, like chemotherapy or HIV patients. These patients are at a specific increased risk because of their underlying immunosuppression, exposure to antibiotics, exposure to healthcare settings, or some combination of those factors. Those with comorbid conditions like IBD are at a 33% more likely to suffer recurrent CDI. Patients with IBD are at an increased risk of not only primary CDI but also recurrent disease and increased morbidity and mortality. Patients with CKD and end-stage renal disease have an approximately 2 to 2.5-fold increased risk of CDI and recurrence, a 1.5-fold increased risk of severe disease and mortality. There may be an important role for vitamin D in protecting against CDI, with low levels being an independent risk factor among patients with community-associated disease, older patients, and those with underlying inflammatory bowel disease. A case study found that patients might be at 5 times increased risk for CDI. Another risk factor is gastrointestinal surgery or any manipulation of the GI tract, including tube feedings. Also, there has been an association between use of stomach acid-suppressing medications and C. diff. In a retrospective study of 754 patients with healthcare-associated CDI, continuous use of PPIs was independently associated with a 50% increased risk for recurrence.
C. diff infections can range from symptomless to mild or moderate diarrhea, to fulminant and sometimes even fatal pseudomembranous colitis. Some of the symptoms of C. diff are diarrhea, which includes the passage of blood or mucus in the stool, as well as fever. Our C. diff patients may also suffer from cramping, abdominal discomfort and pain. They might also have nausea and suffer from a loss of appetite, as well as weight loss. Some complications of severe C. diff colitis include dehydration, electrolyte disturbances, hypoalbuminemia, toxic megacolon, bowel perforation, hypotension, renal failure, systemic inflammatory response syndrome, sepsis, as well as death. A C. diff case is defined as a case of clinically significant diarrhea or toxic megacolon without other known etiology that meets one or more of the following criteria. First, either the stool sample yields a positive result for C. diff toxin A and or B, or a toxin-producing C. diff organism is detected in the stool sample. The second criterion includes that pseudomembranous colitis is seen on an endoscopic examination or a surgery, and in the third case, pseudomembranous colitis is seen on a histopathological examination. The criteria for clinically significant diarrhea include 3 or more diarrheal stools in a 24-hour period or less, or 6 diarrheal stools in the past 36 hours. And since it's not always possible to wait 24 to 48 hours, sometimes diarrhea plus abdominal cramping have also been used. The diagnosis of C. diff is made through the microbiological testing of fecal samples and through the detection of C. diff by culture and or by detection of its toxins. Some tests that are used in the C. diff detection are enzyme immunoassay, which is faster but not sensitive, and it has a higher rate of false positives. Polymerase chain reaction, which is sensitive and can rapidly detect C. diff toxin B gene. It's also highly accurate. And the cell cytotoxic assay. And the cell cytotoxic assay looks for the effects of the C. diff toxin on human cells, and it is very sensitive, but it's less widely available and requires 24 to 48 hours for the test results. So while the sensitivity of culture is high, it lacks information about its toxigenicity. This means that the results can be delayed by a need for further testing. Basically, what this means is that the tests tell us whether C. diff is present or not, but not whether it is producing any toxins. As a result of this lack of information, large numbers of false positive results may occur, and this in turn has implications and consequences for bed management, patient placement, including things such as potentially unnecessary isolation as well as treatment of patients.